What I'm hoping to do tonight is sort of just, take a little quick whirlwind tour of everything that's sort of new and hot in melanoma. We've had a couple of new developments that really sort of stand out in this last year. And I would say the biggest things are the development of adjuvant therapies, meaning therapies that we give to patients after surgery to prevent recurrence in earlier stage disease, specifically stage 2B and C. And we're going to compare that new standard of care to what's already been going on in more advanced disease, stage 3 disease, and talk about how the choices of therapy are important for patients and what factors as a patient you should consider when you're thinking about being part of an adjuvant therapy plan. And I'll talk briefly about the new approval of a drug called Opdualag, or inhibitor of LAG-3 for the treatment of advanced disease. So, when we talk about the treatment of melanoma, again, we tend to divide it into, 3 buckets, I guess. Melanomas that need only surgery alone for cure, melanomas that surgery cannot cure, that require medical therapy, and then melanomas where surgery can cure, but we think that the offering of medical therapy can improve outcomes. And that had really changed about 5 years ago in 2017. I call it the year the world turned upside down in melanoma, because we had a couple of really important papers come out. The first paper was one that compared different surgical approaches, the melanomas that had in patients who had a sentinel lymph node biopsy and a completion lymphadenectomy versus those that only had the sentinel lymph node biopsy, and found that, in fact, adding more surgery, a completion dissection of lymph nodes after a positive sentinel node biopsy, did not improve melanoma-specific survival. And this changed the way our surgeons practiced to only doing sentinel lymph node biopsies to identify involved nodes in the staging parameters of our patients. Also in that year, we had the first approvals of anti-PD-1 immunotherapy for stage 3 and resected stage 4 disease. This was the drug called nivolumab or Opdivo in the Checkmate 238 trial, and pembrolizumab or Keytruda in the Keynote 54 trial. And the COMBI-AD study, which was looking at targeted therapies in patients with metastatic melanoma that's been resected, treated adjuvantly in the form of dabrafenib and trametinib. And what we found in those scenarios is that, interestingly, as one might suspect, anti-PD-1 antibodies or immunotherapies that were given to patients who had had surgery, and we were looking to improve their outcomes, had very, very similar patterns. And that sort of makes sense because these drugs are really, at the end of the day, very similar. So patients on these trials received surgery, and then they were randomized either to placebo or pembrolizumab in the trial on the left, that's the Keynote trial, or nivolumab or ipilimumab, which is another immunotherapy that has since been discarded as a standard of care, in the trial on the right. And what you see in both of these diagrams is that top line, those curves are pretty separate. So that is to demonstrate that the immunotherapy improved relapse-free survival as an endpoint, meaning that patients that took the drug versus those that did not had an improved time to relapse with a hazard ratio of 0.56, which is a pretty significant hazard ratio for the Keynote 54 and for 0.68 for the 238 study. And what we're still looking at, interestingly, is still looking for that evidence of an overall survival benefit, and not yet seeing it in each of these studies. And I think that that's an important distinction to make from some of our other trials in this space. But nonetheless, I think it begs the question when we meet with patients. It's important for us to make sure that we discuss with them that their time to relapse may be improved by their therapies, but it's not yet known if their actual time in years of survival will improve as a result of taking these therapies. Interestingly, immunotherapy is sort of like, for those of you that may not be familiar, it's a way to sort of aggravate the immune system just enough so that the immune system releases some of its natural brakes that hold your immune system in check from creating autoimmune toxicities, and really allows it to sort of rev up a fight against the cancer. But in doing that, there's sometimes toxicity that develops and in the patient in normal organs as sort of an off-target effect. And I think it's important to note that when these drugs were given, they did have, fairly similar rates, about 15% of serious toxicities. Most of the toxicities were manageable. And for the most part, less than 20% actually resulted in early discontinuation of therapy. Interestingly, on one of these studies, the placebo had a 13% of early discontinuation rate. So bottom line is that we often can administer these drugs, and we need to let patients know there can be serious side effects, but that overall they're very well tolerated. The next turn in the road is a trial of targeted therapy. Now, the difference between targeted therapy and immunotherapy is that targeted therapies are often not an IV infusion, but they're given usually in a pill form. And they're usually given to patients that pretty much have a specific mutation that the medicine is aimed against. And without that mutation, you usually don't qualify to be treated with that medicine. And so in this specific trial, the only patients that had a mutation in a protein called BRAF V600E or K, which is about 50% of melanomas, qualified for the study. And these patients were randomized either to placebo or treatment with the targeted therapy drugs dabrafenib and trametinib. And what was seen, again, what you'll see on that top slide are the relapse-free survival curves. And on the bottom slide are the overall survival curves. And the difference in this trial is there actually is an overall survival benefit with this treatment regimen in comparison to immunotherapy. Nonetheless, the agents haven't been compared head to head, and there's challenges and opportunities with using each approach. So in contrast to immunotherapy, when targeted therapy has side effects, they are usually not permanent or life-threatening. Immunotherapy, they sometimes can be, but they're very annoying and they do interfere with quality of life. And what happens is that they definitely tend to result in treatment discontinuation at a higher rate than our immunotherapies, specifically due to fevers, fatigue, and malaise that sort of result after treatment with these therapies. Nonetheless, though, this is that overall survival benefit I was discussing. Impressive and important to note that, we're actually demonstrating that there's a deep, bend in this curve, demonstrating that patients who take this drug will actually live longer. So an important marker that, physicians look at when we're trying to analyze data is a measurement called distant metastasis-free survival. So melanoma, as many of you probably know, can come back locally. And when that happens, it may be a little bit easier to treat than if it comes back in a distant fashion and invades vital organs. So that's a pretty important endpoint. When this distant, metastasis occurs, it's usually a harbinger of more serious and ominous things to come. So interestingly, the distant metastasis-free survival between immunotherapy and targeted therapy is about the same. And so even though we usually don't do cross-trial comparisons, and these two regimens have never, ever been compared head-to-head, it's important to note that at least with the data that we do have to compare, it looks like there could be a similar benefit from either approach. And so when that happens, you might ask, if I have a patient in front of me who's had a melanoma that's advanced, stage 3, fully resected, no evidence of disease, and has a BRAF mutation, what do I talk to them about, and how do we make a choice of a therapy? So one important approach that's not on the slide is actually the approach of observation. And I bring that up because, typically in surgically resected disease, with our later stages, our stage 3C and D patients, they have, more serious risk of disease recurrence. And I do tend to be a little bit more a little bit more of a proponent of therapy in those stages, but stage 3A patients still can do quite well, over a 90% cure rate with nothing. So oftentimes those patients will be observed. And I think that that's an important thing we have to discuss with our patients, that it's an option and we don't always have to force to treat. However, the flip side of that is my patients who are stage 3C and D, like I just mentioned, I do usually recommend that we do some form of treatment, whether it's targeted therapy or immunotherapy. I often, for the later stages, will resort to immunotherapy because we now know that immunotherapy in stage 4 disease gives superior outcomes to targeted therapy. And I like to think that that may be operative also in the adjuvant setting, although we don't really know that for sure as of just yet. But immunotherapy gives you the gold star of potential cure. So doesn't it mean that adjuvant immunotherapy is always better? So this is a quote that I took from a talk I gave in ASCO, which is our American Society of Clinical Oncology meeting, and I think it was back in 2019. In patients that have a BRAF therapy, the UpToDate, which is one of our literature sources in oncology, was suggesting we always give adjuvant anti-PD-1 rather than targeted therapy because of the superior effects of anti-PD-1 therapy in a more advanced disease population. Well, I think that's a bit of a stretch, especially for stage 3A and 3B melanomas, who have a much lower risk of recurrence than stage 3 or stage 3C or D. And so I like to always talk to patients about other trials that have been really important in terms of the treatment of a stage 3 melanoma patient. This is a trial that was done with just pure targeted therapy alone. And it was actually, it's a little bit primitive now because it was just done with one targeted therapy drug called vemurafenib. It was our first targeted therapy drug. And what it was meant to do was essentially to show that they powered the study statistically that the most aggressive group of melanomas would drive the entire study. And that's our stage 3C patients. And so what happened is that group, the therapy was not effective. And the vemurafenib placebo vemurafenib did not result in a superior outcome. And as a result, the entire trial was statistically powered to be considered a failure. Nonetheless, when you look at the earlier stage groups, you see that nice separation of survival curves between the patients who got treatment and those who did not. And so to me, that actually introduces a very important point that maybe patients with earlier stage disease should more often take targeted therapy, especially since it is less likely to cause permanent side effects that can't be reversed. I think it's very important to go over these data with patients when we're making a choice. I think every patient has their own goals. The goals change. And we as doctors are often very, very bad about asking patients about their priorities. And 75% of the care we deliver is outside of that. And so this is a very loaded and important conversation to have with patients. We need to, when we're talking to a patient about adjuvant therapy, sometimes we must introduce that it's possible that the therapy will still fail. We could go through all this and still have a recurrence, but nonetheless, the purpose of delivering the therapy is to reduce the risk of death from disease. That is the overall purpose. Observation is always an option, although for some patients, I favor it more than others. And we always have to think about what's going on in the patient's life, the cost of medications, the schedule and convenience of the administration, which side effects are tolerable to the patient, which therapies are most likely to interfere with something like fertility, other medical conditions the patient may have, and safety considerations. And one thing that I think is always really important, and this is a very powerful article, there have been cases of even type 1 diabetes that have been triggered by immunotherapy. And that is a hard pill to swallow if you're a patient with, for instance, stage 3B disease, where your risk of recurrence was less than 50%. You opted for adjuvant therapy as the extra insurance policy to do whatever you could to keep the disease from coming back. And then you develop a very serious side effect. And this is a New York Times article, actually, where the patient said, if I had known that, I would have just taken the chance of the cancer coming back. I never would have opted for the treatment. This slide is to really sort of show the landscape of side effects that can occur from both targeted therapy and immunotherapy. If I ever feel that a patient's not understanding what I'm trying to offer, I take these pictures out because I think the one on the left shows all of the immunotherapy side effects, and the one on the right shows the targeted therapy side effects. And I always feel like the visual is really a really important tool to help me explain to patients what could potentially happen as a consequence of treatment. So I don't have too much longer, but I do want to wrap up and talk about some of the other really important developments that are in this space. We now, previously had been looking at, stage 3 patients only for therapy, but now recently we have a new tool for stage 2B and 2C. Actually, it's not a new tool at all. It's immunotherapy. It's what we always like to use to treat melanoma because melanoma is so exquisitely sensitive. And there was a large study that was done looking at immunotherapy versus placebo in patients with stage 2B and 2C disease. And these data are very young and still maturing, but have already led to the approval of pembrolizumab last year for the treatment of stage 2B, 2C melanoma. Again, like I mentioned, this is a large study of almost 1,000 patients that were divided into placebo versus the drug. The median treatment duration was about the same, 11 months. And what you see on this slide is that the characteristics of the patients really sort of they're pretty equally distributed, and they do represent what we see in patients with melanoma. The recurrence-free survival, again, those curves are separating. Very interesting to see this at such an early stage. To me, that implies that this benefit is quite real. But nonetheless, I think what it's important to note is that we didn't see what we expected in the more advanced tumors. So our stage 2C patients are at higher risk of recurrence than our stage 2B. When you see these curves crossing, that means we're not seeing what we expected to see. So that's a little bit of a surprise that the stage 2B tumors tended to do a little bit better than the stage 2C, and we're still gathering data to understand this phenomenon a little better. When I go over these slides with my patients, again, I do take the time to explain what a hazard ratio is and why that's important to the patient's health. The lower the hazard ratio, the more of a benefit they're going to be receiving from a therapeutic treatment. And our stage 2C patients, that the hazard ratio is on the higher side. I will note that immunotherapy does tend to influence patterns of recurrence to the point that the patients who got treatment had lower incidences of recurrence. And the side effects are pretty much what we already know about immunotherapy in general, that it's a tolerable therapy, but can occasionally lead to serious side effects that can be permanent, even life-threatening. Luckily, in this trial, there were not treatment-related deaths. I'll take a slip. So in summary, we now have an important tool to treat even earlier stage disease with another relapse-free survival benefit, but these data are still young. And I think if you were to break it down, you still need to treat about 10 patients to benefit 1 or 2. And to me, that means we need to spend a lot more time trying to understand upfront and develop biomarkers from tumor and blood, which of the patients are going to benefit from the therapy ahead of time. That's going to be pretty challenging, but it's something I think we're up to the task for. All right, so I'll just close with a couple slides on our most recent approval, which is a drug called Opdualag. And Opdualag targets this protein LAG3 that's in the middle of the slide. LAG3 is yet another one of those brakes on the immune system to sort of keep the immune system in check that we're trying to block in order to fight cancer. And in this trial, what they did was they took patients that had stage 4 disease, and everybody got the nivolumab, which is the baseline immunotherapy. And then nivolumab with the new drug, now it's called relatlimab, Opdualag, anti-LAG3, you name it, we can call it a lot of different things. And like many times today, we're seeing separation in curves and progression-free survival, 47.7 to 36 months on this slide, and that the median progression-free survival is not yet reached, which is always a good sign. That implies, again, that this is a real treatment-related benefit. And that essentially the overall survival curves, again, they're still sort of coming apart, but we need to follow this further. Again, these data are still quite young. They were just released a little bit, almost a year ago at this point in time. I think what's important to show is that, we do have other combination therapies on the market, and they can induce a higher response rate and maybe longer PFS, but they also have more toxicity. I think that's really important for us to remember when we're trying to talk to our patients about whether this new particular approach would be a good one for the treatment of advanced stage 4 disease. I find that I am using this in my patients where I don't have very, very worrisome signs like lesions in the brain, lesions in the liver or spleen, or a high LDH, which is an index in the blood of a very active melanoma. So my conclusions for this slide deck are that the patients with the least amount of disease may be the best group to treat with targeted therapy. That's that BRIM8 study that I showed you. And that sometimes that BRAF targeted therapy could be curative in the adjuvant setting, although typically it's not in the metastatic setting. Whereas immunotherapy can be curative in both settings, in adjuvant settings and metastatic settings. But it's unclear which stage 2 or even stage 3 patients are going to benefit most from adjuvant treatment. And we need some better biomarkers that can tell us this up front. Finally, we need more head-to-head comparisons with these treatment approaches. We have a lot of trials that we're forced to compare to each other after the trial's done. Not ideal. And so I think that begs the question that there's still really a lot of room for clinical research in the treatment of melanoma. And finally, there's an art to choice of therapy. And that really involves looking not only at the biologic behavior of the primary tumor, but patient-centered considerations and balances of comorbid conditions. I think that's my last slide. And if I have a minute or two, I'll take some questions.
Thank you, Dr. Mehnert. That was so informative, and we really appreciate you being here with us tonight. If anyone has any questions or would like more information about a clinical trial, what would you recommend? Because a lot of times on these webinars, I get emails after from patients who are looking for more information. So what would you suggest?
Right. So clinical trials, like I said, are still a really important mainstay of melanoma therapy. We do have very good standards out there, and many patients will do well. And you might argue that many of them won't need the trial, but I always say that making time to hear about studies in the initial consultation is worth the 1 to 2 week delay that it may cost you to getting started on treatment. I think as patients, the impetus to want to start therapy is a very, very strong feeling. It's strong emotion once people get a diagnosis of cancer. Take the time, shop around, and hear what trials might be available to you. None of these therapies were in existence when I finished my fellowship in 2007. And so that just goes to show you, I've been doing this a little bit over almost 15 years now, I guess, a little more than a decade and a half, but just what can happen in that time frame and how powerful that research can be.
Very well said. Well, thank you so much for being here with us tonight. We appreciate it. And Dr. Hale, I would like to turn it over to you. Dr. Hale is going to talk to us tonight about prevention and early detection. So Dr. Hale, take it away. Oh, Dr. Hale, you're muted.
Yep, I'm good now. Yep.
There you are.
Good afternoon, and thank you all for being here. Thank you, Rachel, for organizing such a great event. And I know Janice, my colleague, just spoke about treatment of advanced melanoma. I would like to talk about steps a little earlier that you can take, the importance of early detection and also prevention of skin cancer, and also just some general tips about sun protection. Now that the weather is finally sunny and beautiful, we should all pay extra attention. I'm a clinical associate professor here at NYU. I'm also a senior vice president of the Skin Cancer Foundation, and I'm in practice in dermatology in New York City. So first, just some words about sun damage. We know that up to 90% of skin cancers are associated with unprotected exposure to ultraviolet radiation from the sun. But we also know that up to 90% of the visible changes of the skin that are commonly attributed to premature aging are also caused by sun damage. So this is a really important topic. These are just some signs of sun damage. This is something I see in my practice every single day. And while I specialize in skin cancer, I also perform a lot of treatments to improve sun damage and improve the quality of the skin. So as you see here, we see signs of chronic sunspots, wrinkling, leathery texture to the skin, enlarged pores. And a lot of this is from unprotected sun exposure that's cumulative over the years. So we know that unprotected or overexposure to ultraviolet radiation causes some acute and some chronic changes. Acute changes, which many of us have likely experienced, are in the way of sunburn, like redness or erythema and edema or swelling of the skin. We also can see tanning and hyperpigmentation. But we also can see some chronic effects of sun damage, including suppression of our immune system, photoaging, or some of those pictures like I just showed you earlier, and most importantly, photocarcinogenesis, which means some mutations induced by the sun that lead to skin cancer. So the American Academy of Dermatology suggests that regardless of your skin type, a broad spectrum sunscreen with an SPF of at least 30 should be used year round, every day. And it's recommended for daily use because sun protection is the principal means of preventing both premature aging and skin cancer. So now we'll talk about skin cancer. And I will say that many of my patients have overlap. The common denominator in my practice is overexposure and unprotected sun exposure. So sometimes patients will come in for treatment of brown spots or some sort of sun damage, and I make every patient have a full skin examination because skin cancer is the most common form of cancer in the United States. It's thought that more than 9,500 people are diagnosed with skin cancer in the United States every single day. And because it's the most common cancer, it's actually more common than breast cancer, prostate cancer, lung and colon cancers combined. So that's how common it is. But what's so important and why you're here tonight is that it's also thought to be the most preventable cancer because we do know in most cases what causes it. And also it's the most curable when it's caught early. So it's really important that we're all aware. It's thought that 1 in 5 Americans will develop skin cancer, some form of it, at some point in their life before age 70. And this includes patients of all skin types. So while skin cancer is still more common in fair-skinned individuals, we're seeing increases in patients with darker skin, Latino Americans, Asian Americans, African Americans. We're seeing an increase across the board. So it's very common. We will get to melanoma at the end of my talk, which is what Janice just spoke about. But first, I'll talk about the more common types of skin cancer, which are basal cell and squamous cell carcinomas. It's thought that about 80% of new skin cancers are basal cell carcinoma, while about 16% are squamous cell carcinoma and 4% are melanoma. However, while melanoma accounts for less than 5% of skin cancers, it does account for about 3/4 of skin cancer-related deaths. I will note that recently there has been a rise in death from squamous cell carcinoma, which we'll talk about, but this oftentimes is associated with immunocompromised patients, organ transplant recipients. These patients tend to get much more aggressive squamous cell carcinoma. But melanoma is usually the one that we really want to catch early, because when we catch it early, it's almost always curable. So the non-melanoma skin cancers represent half of all cancers diagnosed in the United States. And this includes basal and squamous cell carcinoma. It's thought that 40 to 50% of Americans who live to age 65 will have basal or squamous cell carcinoma at least once. But fortunately, both basal and squamous cell carcinoma have a better than 95% cure rate when they're detected and treated early. Although they may be less aggressive than melanoma, they can be highly disfiguring if they're left untreated. And this is very important for patients to understand. And some of the pictures I'll be showing in a minute can be very graphic. So you may want to look away, and I'll warn you again when I get to that. But a lot of times patients say to me, well, if this basal cell is never going to spread, is never going to kill me, why are you cutting my face? Why are you doing Mohs surgery to remove it? And I explain that they're best treated when they're still small and confined to the skin, so they don't cause bigger problems. The mortality is very low for basal and squamous cell carcinoma, about 2% of those, mostly from metastatic squamous cell carcinoma. So risk factors for these non-melanoma skin cancers, cumulative sun exposure. So the longer we live and the more that we're exposed to ultraviolet radiation, the higher our chances get for developing these cancers. They're significantly increased in fair complected people above the age of 60, although we are seeing more, like I said, in all skin types and younger patients as well. Because basal and squamous cell carcinoma are directly related to chronic sun exposure, they most commonly occur on the upper arms, the head, the neck, areas that are exposed to chronic solar radiation. And again, people with fair skin, light eyes, light hair are at most risk. So basal cell carcinoma, also known as BCC, again, it's the most common skin cancer and therefore the most common malignancy overall. It has a very low risk for metastasis, but again, it can be highly disfiguring by invading local tissue. As I mentioned briefly before, the number of women under age 40 diagnosed with basal cell carcinoma has more than doubled in the last 30 years. And some of this is due to tanning habits, which I'll talk about soon as well. So the classic presentation for basal cell carcinoma are pearly papules with slightly elevated rolled borders. So that means they're kind of shiny, looking like a pearl. They oftentimes have a crusted indentation in the center. And as the growth enlarges, telangiectasias, or tiny little blood vessels, develop on the surface like this. Sometimes they appear like a cut that doesn't heal or a pimple that doesn't go away, an open sore that bleeds or crusts. This lesion on the nose here, which is a basal cell on the right, it can be somewhat inconspicuous, but when the patient says to me, I think I cut myself shaving, or I had a pimple here and it's been 2 months, it hasn't gone away, that can often be a sign of a basal cell. This next slide is quite graphic, but just to show, we don't see cases like this in New York City so much anymore, but some of my colleagues in certain states where there's only one Mohs surgeon per state, sometimes patients let them grow this big, and this is what can happen if basal cells are neglected and not treated early. I'll now talk about squamous cell carcinoma, or SCC, which is the second most common type of skin cancer. This is the one that's most directly correlated with chronic sun exposure. So this occurs most often in areas that are exposed every day, year round, like the head, the face, the neck, the ears, the lips, and we'll talk about this. It can also be correlated with cigarette smokers. So these can be very common on the lower lips, that combination of cigarette smoke and chronic sun exposure. And SCC can also occur in association with burn injuries, scars, and also human papillomavirus, which is why we screen so actively for this and our gynecology colleagues as well. Unlike basal cells, squamous cell carcinoma does have moderate metastatic potential. So if it's not caught early, it does have that potential to spread through the body to the local lymph nodes and beyond, but especially in patients that are immunocompromised or organ transplant recipients. These are some classic presentations of squamous cell carcinoma. Because these develop on the outermost area of the epidermis, because of the chronic effects of sun radiation hitting our skin, we often see a rapidly proliferating epidermis, which translates into a thick, scaly surface. Oftentimes, these lesions occur warty, scaly, crust-like. They sometimes rapidly increase in size. And again, they often occur in areas that are exposed year-round, like the ears and lips depicted here. They can get what we call as dermatologists hyperkeratotic, which means that they're proliferating so rapidly, they're producing so much keratin, so much scale, they can look like warts or even what we call horns, cutaneous horns coming out of the skin. And again, can be just a patch, like a patch of dry skin that doesn't heal, a crack in the lip that seems to bleed and crust. These are signs that they should be biopsied to rule out squamous cell carcinoma. And again, these are more neglected, ones that have not been treated. They can get infected, they can invade local tissue. So although basal and squamous cell are not serious, they're best treated when they're caught early. Now we'll talk about malignant melanoma, which can be the most serious type of skin cancer, and why we should try to spread knowledge about this so we can get good at detecting these cancers while they're still curable, before they spread and patients need immunotherapy like we just heard about. Melanoma is increasing in incidence. It's thought to have increased 700% over the past 50 years. The lifetime risk in the 1930s was about 1 in 2,500 Americans, whereas this year, according to the American Cancer Society, it's thought 1 in 38 Americans will develop melanoma. Some risk factors for melanoma: more than 5 sunburns or greater or equal to 5 sunburns at any age doubles your risk for melanoma later in life. But even 1 blistering sunburn in childhood or adolescence doubles your risk for melanoma. Also, the use of indoor tanning devices, tanning beds. It's thought that the first exposure to tanning beds, and I'll talk more about this in a minute, increases your chance for melanoma by 75%, according to the Skin Cancer Foundation. Up until age 39, women are almost twice as likely than men to develop melanoma, but oftentimes those are caught earlier. And after about age 40, the incidence of melanoma in men surpasses that in women, and that trend continues. And oftentimes, possibly because men aren't as good about coming in to get routine screens, often their melanomas are diagnosed at a more advanced stage than in women. So we really want to make sure everybody knows to get checked. It's thought 1 person dies from melanoma every hour in this country. It is a leading cause of cancer-related death in young women. Again, older Caucasian males have the highest mortality rate. But despite all this, it's really important to know that melanoma has a 99% 5-year survival for those that are detected and treated before spreading. How do we diagnose melanoma? We talk about the A, B, C, D, E's, an easy to remember mnemonic. A is asymmetry. So where normal benign moles are often symmetric and round, many forms of melanoma are asymmetric. So if you draw a line down the middle, you would not create matching halves. B is border irregularity. So again, benign moles tend to have smooth, even borders, but borders of melanoma can be jagged, scalloped, notched, as seen here. C is color variability. Benign moles are often tan, light brown, even dark brown. But when you see various colors or various shades, this can be a sign of a concerning lesion that could be melanoma. And as melanomas progress, you'll even see signs of red, white, and blue that could indicate more advanced melanomas. For many years, D stood for diameter, because early melanomas and advanced melanomas tend to grow larger than common moles. We used to say generally to the size of a pencil eraser, which is 6 millimeters, but we've gotten much better at diagnosing melanomas. And recently at the Skin Cancer Foundation, we've talked about a new paradigm, which is including D for darkness, because sometimes, like these 3 melanomas depicted here, they can be small. These can be 3 to 4 millimeters or less. And although they don't necessarily follow all the other ABCDs that we've talked about before, if you see a really dark mole, especially if it's new, it should definitely be biopsy because that could be melanoma, as these 3 lesions were. E was added more recently, and that stands for evolution or change. And I think this is the most important of the algorithm because E, evolution, if something is changing, especially if a patient notes they have a mole that's changing, it's very important to evaluate that and probably perform a biopsy to rule out the possibility of melanoma. I just wanted to show a couple unique types of melanoma. They don't follow the ABCDEs, but a nodular melanoma, jet black nodule, these tend to have a poor prognosis. And although they appear homogeneous and smooth, they can be very aggressive. African Americans are at risk for a specific type of melanoma that occurs on the soles of the feet called acryl lentiginous melanoma. Often these are diagnosed later because people think they're a bruise or just dyspigmentation, but they often occur in patients with darker skin and they can be much more aggressive. So when we check the skin in the office, we always make sure to check under the feet and in between the toes. And then you see here just some pictures of advanced melanoma. And when you start to see the white, that actually can be a sign that your body's trying to get rid of it and it's revving up the immune system, and that could be a sign of more advanced disease. However, this is more realistic. This is just a melanoma I diagnosed 6 years ago in my office. The patient was unaware of this lesion, but you can see that it does show some asymmetry, some irregular borders, some variation in color. So something like this definitely should be biopsied and treated as promptly as possible. Now, fortunately, this is why we're talking about early diagnosis. If melanomas are caught early, they have very high cure rates. Their prognosis is directly proportional to the thickness of the melanoma, and this is measured in fractions of a millimeter, also known as Breslow's thickness. The estimated 5-year survival rates is very high when they're stage 1 or less than 0.76 millimeters in thickness. Their survival rate is 93 to 100%, but once those tumors start to stay around the skin, invade deeper into the dermis, that's when they gain access to blood vessels and lymphatics. That's when they spread throughout the body, and that's where the prognosis becomes really dismal and where we look forward to more innovation in immunotherapy to help cure these patients. So for melanoma, the risk factors can be similar to the non-melanoma skin cancers in that light skin patients are at higher risk. Family history is very important for melanoma because we know there's definitely a strong genetic component. But some other risk factors, which are interesting, we talked about basal and squamous cell carcinoma being more a product of chronic cumulative sun damage, whereas people that get melanoma often have this intermittent, intense sun exposure. We call them sunbursting because they may have a sunburn when they were younger, or they might go to tanning beds where they have this extremely strong emission of radiation. And those intense sun exposures predispose them to mutations that occur more in melanoma. Also, patients with numerous moles, normal and also atypical moles known as dysplastic nevi, these patients are at risk for getting melanoma, both in their pre-existing moles. Mutations can occur from sunburn, sun damage, and turn these moles into melanoma, but even more commonly, they can occur de novo in normal skin, but patients with a lot of moles are at greater risk, even in developing melanoma in their normal skin. So it's just important that everyone understand ultraviolet radiation over 13 years ago was upgraded to the highest cancer risk category by the World Health Organization. It's up there with arsenic and mustard gas. It's linked to more cancers worldwide than any other carcinogen, but rates of unprotected sun exposure remain high despite this known link in development with developing skin cancer. Artificial tanning, I just want to say a word about this, that also tanning beds were categorized as carcinogenic to human beings. It's banned for individuals in Europe under age 13. And in the United States, more than 35 states have imposed restrictions on tanning facilities. Something that I learned recently, according to the Skin Cancer Foundation, more people develop skin cancer because of indoor tanning than develop lung cancer because of smoking. And that to me was a very powerful statistic. So what can you do to minimize your chances? This is the most important thing of my talk. Contrary to popular belief, only about 25% of your lifetime sun exposure is acquired before age 18. So it's not too late. Sometimes people say the damage is already done. I've already used tanning oils and I got sunburns when I was younger. We know it's an ongoing cumulative process and it's never too late to start protecting your skin. We want to try to avoid peak hours of sunlight between 10 a.m. and 4 p.m. when the sun rays are the strongest. We want to use daily sunscreen of SPF 30 or higher. When possible, wear sun protective clothing. This has become part of my routine when I exercise outdoors, when I swim in the ocean, I'm always wearing long sleeve sun protective clothing. We want to teach children sun protection early. These are some pictures of my kids when they were younger. And if you teach them when they're young to wear long sleeve sun protective clothing, then they go away to sleepaway camp and you're very proud when you see that they're wearing that, even when you're not around to tell them to. Avoid tanning salons. As you've heard me say, these new sun lamps emit doses of radiation that can be 12 times more intense and more dangerous than the sun. Like you heard earlier, exposure to tanning beds increases the risk of melanoma by 75%. It is a human carcinogen. And for people that like to look tan, sunless tanners are a safer option. People often ask about vitamin D. It's better to get your vitamin D through a healthy diet that may include vitamin D supplements. You want to examine your own skin, be familiar with your moles, and if you notice anything new or changing, see a dermatologist promptly. Because skin cancer is the most common cancer. It's often preventable and curable when it's detected early. So thank you so much for your attention, and I'll take questions at the end.
Thank you, Dr. Hale. That was very informative and a great reminder. I know the weather is starting to get nice and everyone's outside.
Hi.
But we want to be safe about it. So thank you for that. All right, moving on. I would like to introduce our next speaker, Dr. Megan Winner, who is a surgical oncologist, and she's going to talk to us tonight about surgical options treating melanoma.
Okay. All right, this looks like it's working.
Yes, you're good.
Great. Thank you very much for the opportunity to speak. When I thought about this talk, really the technical demands of surgery for melanoma or for skin cancer are not all that tremendous, but rather the decision-making around when to do surgery and how much, maybe when not to do surgery, and how those questions and answers are changing in my field, I think are the most interesting aspects of what I do. So the way that I'll structure the talk for the next couple minutes is I'm going to start out with some philosophical underpinnings on how I approach a cancer as a surgical problem. Melanoma is one of the several cancers that I treat. I'll talk about some of the biologic aspects of melanoma that have already been touched upon, which underpin why I do certain surgeries, the basic surgeries for melanoma, which I'll touch on, and that'll then lead into kind of a bulleted list of what are the interesting aspects of my job and where I think the field is going. I give a talk to the medical oncology fellows every year with the lofty title of Principles of Surgical Oncology. And I start out by telling them that this is what my brain looks like on a daily basis. I am always trying to balance my technical abilities and the tools that I have with a healthy humility against the fact that the cancer biology and the behavior of the cancer may dictate the outcomes beyond what I can intervene on with my metal scalpel. And I know that sounds anathema to be saying that as a surgeon, so I'll repeat it again. The metal of a scalpel can rarely intervene on the biology of a cancer. It sounds weird, and I'm going to come back to it a couple times, and I think you'll understand what I'm getting at. And those two kind of dichotomous things that I have to hold in my head at the same time are also balanced against two very human urges: the need to act when there's a problem, balanced against the concern that I might do harm by something that I do and wanting to minimize that harm. Oh boy. There we go. So before I talk about what I do for melanoma, let's talk about melanoma specifically, because that's where the complexity of the surgery comes in. these are estimates for when we come to the end of 22 and all of the data come in, there will be about 100,000 cases of melanoma that will have been diagnosed, and there will be about 7,600 deaths. That ratio is getting better. Dr. Mehnert reflected on that in her talk. The death rate of melanoma is going down. It's certainly better than it was a decade ago, but melanoma still remains the most deadly of the skin cancers. And the reason isn't because people die from something on their skin. The reason is because, as Dr. Hale just alluded to, the behavior, the aggression, the ability to spread of a melanoma is entirely related to how much it has advanced before it gets to the point where we notice it and we treat it. So what you're looking at is you're looking at the survival rate of node negative patients, patients who come and who were diagnosed with a melanoma and they didn't have any lymph node, they didn't have any melanoma in their lymph nodes, and they didn't have any distant disease, and they had the best surgery possible, yet still notice that for the thicker tumors, the tumors that had penetrated deeper into the skin at the time that they were identified, those individuals still have a real measurable risk of dying from their melanoma in the next 10 years. And naturally, that happens because the melanoma returns. Is it because the surgeon didn't do a good surgery? No, the surgery is prescribed, and I'll tell you about that in a minute. It's because I come back to that principle of, to a certain degree, at some point in a cancer, the surgeon's scalpel cannot change the behavior of that cancer, and I have to keep that humility in mind as I approach my field. But then why do surgery at all? I'll come to that in 5 seconds, but notice what the outcome is for the individuals with very, very thin cancers. Those individuals, all they require is just removing the tumor, and that's the end. They're cured. So if we get it early enough, to echo something that's been said by all of the speakers so far, it really is treatable with an excellent outcome. So if I can't cure all melanomas with surgery, what can I do with my scalpel? And there's a couple of key bullet points that I need to keep in mind that I can do and that will remain my job even as the field is happily changing. By cutting out the tumor, I am at the very least providing accurate staging of how extensive that tumor is. The biopsy may have done that job for us, but removing it altogether helps us understand we have a complete understanding of that tumor. That helps us advise patients, and it helps us predict who can benefit from medical therapy. I'm going to talk about plus or minus lymph nodes in a minute, but the other aspect that is emerging in my field is genetic testing of the tumor that I remove can also be used to predict which therapies might be most effective for patients. So that first approach to that tumor is really important. The other important thing I have to take into account is appropriate excision of a margin around a melanoma. The way that I describe it to patients is that our understanding of the behavior of melanoma is that unlike squamous and basal cell carcinomas, which tend to be confined to the border, yes, they can be locally aggressive, but they tend not to extend beyond what we can see. Melanomas are known to put out feelers underneath the skin. That's a layperson's explanation for why do I have to cut out so much. For the thinnest melanomas, for the 1 millimeter, I have to cut 1 centimeter around the melanoma. That's about ½ an inch. And for the thicker melanomas, right now, the rules say I have to cut 2 centimeters, nearly an inch around the melanoma. If we all take a moment and think about our own skin, taking a quarter out of an arm or a leg might be easy to pull it together. But if you're talking about taking a good silver dollar out or even more, that's going to be hard to pull those two edges of the skin together. And so that extra excision sometimes results in the need for some plastic surgery reconstruction and can have implications for function. Imagine me taking that much skin out of an elbow or a knee. I also need to make sure, because one skin cancer indicates that that individual is at risk for another skin cancer, I have to keep in mind that someone might need to come back here another day and remove another skin cancer, and that goes into my thought process. Naturally, I want to make sure that I balance the oncologic needs of the surgery with making sure that I have an excellent functional outcome and cosmetic results. And before I move on to the next slide, a lot of my patients who I see in the office ask me why Mohs surgery isn't available for melanoma. And there's two answers to that. Number one is that the margin that we need around the melanoma makes the advantage of Mohs surgery really minimal. Mohs surgery is a procedure where a trained dermatologist will excise a skin cancer with the thinnest ever of margins. Given that that's a risk of leaving some behind, they won't finish their operation and let the patient go home until a pathologist in the back room has declared the margins free of disease. The immediate feedback requires processing of that pathology specimen that is not available to tell us if melanoma is at the edge. So the processing required for that immediate feedback isn't available. Let's talk a minute about lymph nodes. I think everyone is aware of the blood circulatory system. We know that the heart pumps oxygenated blood to our organs and that the veins bring back deoxygenated blood from our organs to be circulated again. The body's immune system has another circulatory system called the lymphatic system, and lymph nodes are substations along that circulation system. Those substations have a really important function for our immune system. They're the place where our body gets information about what's going on in the outside world. For instance, when we have a cold or a rhinovirus in our oropharynx, sometimes the lymph nodes can get swollen in our neck. That's a sign that the body's detected a problem and is mounting a response. Cancers anywhere in the body, including on the skin, can also use that pathway to spread beyond the organ of origin. And when that risk is appreciable enough to justify looking closely at those lymph nodes, a surgical procedure comes with the excision that I just described in order to make sure that we get the appropriate information for the lymph nodes. Right now, that decision point is between the 0.8 millimeter and the 1 millimeter mark. So quite early, when it is quite early in the depth growth of the melanoma, when the risk of lymph node metastases is appreciable enough to justify this procedure. But if we've got so many lymph nodes in our body, how do I know which one is the most important for the patch of skin that bears the melanoma? Well, to do that, I do a sentinel lymph node biopsy procedure. Sentinel is synonymous with guard. Those are the lymph nodes that guard that patch of skin. And on the day that I take out the melanoma, but before I make my cut, the patient goes down to the radiology department, gets an injection of a gentle radioactive material. The radiologist takes a picture as that radioactive material goes through the lymphatic channels and settles in the lymph node that informs that patch of skin. And then I can detect that in the operating room. So out comes the melanoma and the 1 or 2 or 3 lymph nodes that are important for that patch of skin. And that's what it looks like. That's one of my patients. It was actually an injection right, a melanoma right here, and you can see the projection of the groin lymph node. So let's review for 10 seconds. I told you that I have a lot of competing issues in my mind as I approach a surgical problem, approach a cancer problem oncologically, that I want very much to consider the biology of the cancer into the decisions that I make, and I want to make sure I don't do more than is necessary. I've told you Megan's rule number 1 of cancer surgery, which is that a scalpel cannot change the biology of a tumor. And we've talked about the melanoma tumor biology that leads to the wide local excision of the primary melanoma and the sentinel lymph node when appropriate. Now I want to talk to you about where I think the field is going, and this is where my life gets very interesting. And I'll come back to that philosophical principle. Megan's rule number 2 is really just Megan's rule number 1 rephrased. I try to impart to my trainees that never in the history of surgery for cancer has doing more surgery to achieve the same goals, i.e. get information, minimize local complications, get information about the lymph nodes. Never has doing more to achieve the same goals resulted in better survival. And maybe to make this clear, I'm going to come back to an example that might be more familiar to us than melanoma, which is breast surgery. The picture up at the top, which I hope is not too graphic, is the picture of what we now term to be a classic Halsted radical mastectomy. Halsted was a surgeon operating at the turn of the 19th century, and he treated women who presented with breast tumors. And he would do surgery, and he was repeatedly troubled by the fact that the cancers would come back. He thought it was his fault that he wasn't cutting enough. And so he cut more and more and more until his standard of practice involved removing the entire breast and all the skin, removing the muscle out from underneath the breast and all of the lymph nodes underneath the arm. This was incredibly disfiguring. It was very painful, and it led to a tremendous detriment in quality of life, for instance, with the shoulder girdle, as well as swelling in the arm that can result when you disrupt all of that lymphatic circulation. The lesson I take from there, so consider what we do now. Most breast cancer is treated with a lumpectomy and radiation. Most women get a sample of the lymph nodes removed, but not all. Is it because we're better or our scalpels are sharper than Dr. Halsted's? No, it's because since that time, the other treatment options available have gotten better, which have allowed the surgeons to recede into the background. And so in that theme, the field of melanoma surgery for me is changing in the following ways. 10 years ago, when I started my practice, if I pulled out a lymph node from a patient as a sample and it had cancer in it, I told that patient with a straight face, I think it's most important for your survival that I go back in and I remove the rest of your lymph nodes. But 80% of the people who went through that never had any cancer left over in their lymph nodes, leading to a sneaking suspicion that maybe we were overtreating a lot of patients. Indeed, a randomized trial then demonstrated that it was safe to leave in the remaining lymph nodes even after a positive biopsy and just follow those patients very, very carefully, to only act if lymph nodes grew, suggesting that there was melanoma left behind, and demonstrating that doing that did not diminish survival from this disease. See Megan's rule number 2. There are ongoing trials for less surgery. I told you about needing to remove a silver dollar from someone's skin. That's based on some trials that were run in the 1980s and 1990s. NYU is poised to engage in a multinational trial, randomizing that 2-centimeter margin to the 1, believe it or not, had never been done before. And boy, wouldn't that result in a whole lot better ease of surgery for patients. And then linked to what Dr. Mehnert had discussed before, there are ongoing trials poised to help us understand if applying immunotherapy before surgery or targeted therapy before surgery might reduce the amount of surgery required or might even obviate the need for surgery. And that brings me to the bookend of my philosophical approach to surgical oncology, which is the evolution of a surgical field in cancer. In the most primitive forms of a field, the surgeon is paramount. Generally, that's a signal that there aren't very good medical therapies involved, and that if surgery isn't available, the patient needs to start getting their affairs in order. Later in the evolution, medicine is an adjunct. Surgery is most important, but the medical oncologist can come in and sort of clean up and boost the effect of surgery with medication. I think now we're moving into an era for melanoma where surgery is starting to become an adjunct. Surgery is important for making informed choices, but really now we're intelligently sequencing medical therapy and surgical therapy to boost the effectiveness of both. We're trying to have patient and tumor directed choices rather than a blanket approach. And that is the step just before the next evolution, which is surgery will really recede into the background. Surgery will be for rescue only, for instances where the medication isn't working or it's working over here, but not over here. So Megan, can you go pick this off so that we can continue on our therapeutic plan? And maybe surgery is just as a consolidation, just to provide that information, all leading up to nirvana, which is, I phrase as either the cancer pill, when there's just a single pill that we take to cure all cancer, I'm waiting for it, or that machine in the dystopia sci-fi movie Elysium, where you laid in the machine and it scanned you and it zapped all your cancer cells. But really, another form of nirvana is prevention. The highest cure rate of any cancer comes when you can prevent it from happening. And nights like these are, I think, a tremendous move in that direction. So I'll stop there and I'll thank you very much for the opportunity.
Thank you, Dr. Winter. That was very informative. We really appreciate that. All right, last but not least, I'm going to turn the program over to Dan Latorre from the Skin Cancer Foundation. And Dan, we thank you for collaborating with us tonight.
Thank you. I appreciate that. Let me just, there we go. Thank you so much for the opportunity. I really appreciate it. And really great opportunity for me to talk to you a little bit about how what you're hearing tonight from the physicians is really all tying in and what the foundation's role is in bringing that out to the patients. I think it's really important to know that there's so much great information out there, but a big part of saving lives is bringing that information to patients so they can understand it. And that's where organizations like ours come in. I am not a physician. I am not a scientist, so you won't hear anything particularly complicated from me. We rely on working with our doctors and our experts for that type of information, and they're really the backbone of what we do here at the foundation. But what we do is take sometimes some very complicated topics, complicated informations and concepts, and boil them down and make it easy for people that are either dealing with skin cancer or wanting to avoid it altogether. So the Skin Cancer Foundation does have close ties with NYU, all the way back to our founder, Perry Robbins, who started it, Dr. Perry Robbins, who started the foundation in 1979, and his colleagues at that time, to Dr. Sarnoff, Deborah Sarnoff, who's our president right now, and Dr. Hale, who you heard from earlier, who's a senior vice president, along with some other doctors. And they really give us guidance on a lot of the things that we do. You'll hear different things from me throughout the process. I'm happy to answer questions, but I won't take too long. Just really want to give you an idea of who we are and what we do. So formally, our mission is we're here to save and improve lives. We empower people to take a proactive approach to daily sun protection and the early detection and treatment of skin cancer. Because as you heard, prevention is really the first line of defense. If you are not able to prevent it and you are unfortunate enough to develop skin cancer, we want to find it early. And if you are diagnosed with skin cancer, we want to make sure that you feel comfortable and empowered to go get positive treatment, good, effective treatment. We kind of coined the Skin Cancer Foundation the first stop in skin cancer education. That can be boiled down basically into the idea that when people go to a doctor and they're diagnosed, they hear the fact that they have cancer, they hear basal cell, they hear squamous cell, melanoma, whatever it might be, they're running to their phones and they're going to look it up because they don't necessarily always understand everything that they're told at that time because they were just told that they had cancer. So it's important to know that people are going to go online and find us right there. So about 9 million people a year come to our website, anywhere between 25 and 40,000 people each day in the top season, which is right about now. May is Skin Cancer Awareness Month, as you know. So it's important that we put in a lot of time to make sure that people have good, accurate information that makes them feel good, makes them feel that they're understood and gives them what they need to move forward, even if it's just simple information. We have a journal that goes out every year. This is a cover of last year's journal, but it goes out to every dermatologist in the country and it covers some pretty significant topics, but it also covers basics. We just want to make sure that we reach out to physicians every year all around the country to make sure that they can share all of the latest news, they can share the latest information and statistics and try to get everybody on the same page. The American Academy of Dermatology does a great job with that as well, but they cover all types of different skin diseases. We focus just on skin cancer. We have provider.skincancer.org, which is for our medical professionals to go to, where we talk about some of these more complicated type of topics. And we also do brochures and posters for doctors' offices to be able to hand out and educate patients right there on the spot. I think it's really, really important to understand our role in bringing this information out there. It's not to have everybody kind of talking about everything the way we would talk about it. You're going to see a lot of conflicting information out there. Stats are very difficult to come by with skin cancer, but we do our best to put everything forth and make sure that what we do put out there is credible and that people, as I said, feel very comfortable with the information so they can make a decision to move forward. We have a lot of different programs. There's a lot of ways to bring this information to people, whether it be about prevention, whether it be about early detection, treatment, you name it. So we do a lot of different things. We'll call it 360-degree marketing, if you will, to make sure that we do everything we can, both proactive and reactive. This particular program called The Big C, we designed a few years ago. It's a PSA campaign That is a television commercial. It's all around the country. It's been going out for several years. It was basically a talking mirror that we had people asking questions, and it was giving them statistics with the idea that we want people to look at their skin regularly and just say, what's that? Detecting skin cancer can be very, very tricky. We heard Dr. Hale talk about the ABCDEs, about all the different presentations of basal cell and squamous cell. I think really what we wanted to do was look at it and say, what's the easiest thing that we can tell people to do to make sure that they're going to see a doctor? It really boiled down to the fact that people should look for anything that's new, changing, or unusual. You heard Dr. Hale talk about new and changing. We added the word unusual because there are things that don't fit into any category at all, and it's kind of a catch-all right there. But this big C has been very, very popular. We're starting to hear physicians around the country already use terms like new, changing, and unusual, and it can be melanoma, basal cell, squamous cell, Merkel cell carcinoma, you name it. If it's new, changing, unusual, we want people to get to the doctor and have them tell them exactly what it is. Also along the lines of early detection, we have a program called Destination Healthy Skin. Destination Healthy Skin is in its kind of second iteration. We've been doing a program like this for about 12 years. We have an RV that travels the country, and we have local dermatologists in every market perform free skin cancer screenings. Inside the RV, it's customized to have 2 exam rooms, a waiting room, really good lighting. You can see the picture right there. It looks like a doctor's office. And we'll drive around for 3 to 4 months every single year, screen thousands of people. And we know that we're saving lives because we're actually tracking what we call suspected skin cancers, because we're not offering biopsies on the road, so we don't know for sure. But we find anywhere between 20 and 50 melanomas a year and thousands of skin cancers. It's a free service. We're going into areas where people don't necessarily have access to skin cancer screenings. But more importantly, we'll catch people that are just walking to the cleaners or going out to dinner, and someone will say, let's go get a skin cancer screening, and find out that they had a melanoma. So we know we're saving lives. And more than anything, what's great about this program is the people that we're helping directly are those people who are being screened. Outside of that, anybody that sees the RV driving around the road for 4 months is getting that message of looking for something new, changing, and unusual, and you really can't miss it. It's 40 feet long, probably 15 feet high, doing about 10,000 miles a year. So you get that secondary element of education. And then the tertiary element is really the news coverage that we get. We've done everything from national news programs on the Today Show and Good Morning America to interviews at local TV stations where we've had ABC, CBS, and NBC, all 3 of them come out, interview the doctor, interview patients, and then it helps us to reach millions of people with the importance of looking at your skin and really kind of hunkering down on this early detection message. Our seal of recommendation is our oldest program. Many people have heard of it. I think now that you've heard me talk about it, if you go into any CVS or Walgreens and look at the sunscreen aisle, you'll see several products that have our seal of recommendation on it. In layman's terms, I kind of call it the Good Housekeeping seal of approval, but for sunscreen products. And basically what we do is we have over 100 companies with thousands of products that have basically submitted their sunscreen testing to us, to a specific photobiology committee that reviews the science, makes sure that they're doing everything they're supposed to be doing, make sure they've done the proper tests, everything from phototoxicity to contact urgency to make sure it's not bothering your skin, make sure you have the proper SPF and UVA testing in place. And if they pass all those tests, they're awarded our seal of recommendation. We have both an active use and a daily use, and we also offer it for clothing, sunglasses, hats, window film, awnings, umbrellas, you name it, anything that can really protect you from the sun. Its importance is that it dates all the way back to 1981. It really helped put the foundation on the map. It's international. You'll see the seal of recommendation all around the world. And most importantly, we look at it as an educational program because we really want people to take the time to understand what their sun protection is all about. What am I using this for? You don't necessarily want to just take someone's word. You want to make sure that they're doing the right things, and also just reinforce the fact that people need to understand how sun protection works. And that's really what the SEAL program is all about. I think it's something that we're always changing. We're always doing something new with it. It continues to grow. And it's really a solid program that is kind of the foundation of what we do here. you'll notice as I go through this, and if you spend any time on skincancer.org, our website, that our programs are at different stages. Something like the seal recommendation is 40 years old. Something like the Robin's Nest is just in its infancy. The website, Destination Healthy Skin, the Big C campaigns, those are all at different stages. So they kind of mature as they go. The Robin's Nest is something we introduced just a few years ago after our namesake, Dr. Robbins, who really thought it was always important to talk to his patients every night, whether he was doing Mohs surgery on them or something else. He wanted to call them that night to see how they were doing because he likes to treat the patient, not the condition. And what we've done with the Robin's Nest is really kind of create a place for people to reach out to the foundation. And what we try to do is help them find the resources that they need. So we're an informational organization. We're going to give people statistics and definitions, walk them through their journey and everything they need. What we don't do is give people money for hospital stays. We don't give them food. We don't take care of bills. We don't have necessarily support networks for psychiatrists or counselors for people to talk to. So what we do know is that those services exist all around the country. They're well funded, and oftentimes people with skin cancer are left out. So what people do now is they reach out to us, and through the Robin's Nest, we'll point them in the direction of where those services are. So if you have a basal cell and you have some concern, or if you have squamous cell or melanoma and you need help finding a doctor, or you need help paying bills, or you need help getting a ride to the hospital for a treatment, through our Robin's Nest program, as we continue to build it, we're going to be able to help point you in the right direction. So it's another kind of element of the foundation that's growing to increase what we're able to do for people. Our research grants, the committee chair is Dr. David Polsky right there at NYU. So again, our connections run deep. Research is not something that we do in a big way. However, it's really, really important what we do. Our research grants program, we give out about $125,000, $150,000 a year, usually 3 programs, and it's all given to young researchers who are just getting their start on either particular ideas or within their career. We've funded great grants, great projects over the years with some of these small grants, some as small as $10,000, some as high as $50,000. And some have led to great research that's gone on to help people with Merkel cell carcinoma, initial immunotherapies when you go way back. And it's really an excellent way to get younger physicians interested in what's going on the scientific side of things, but also showing the world that we can help give a little bit of money and give them enough opportunity to collect some data so they can go to a bigger organization or the federal government and get big money to run their grants. So it's a really interesting program. Again, been around for a very, very long time, but we're always looking for ways to make it bigger and newer. And you'll notice throughout this whole thing, we use the word you a lot. Part of what we do to make people feel comfortable is really talk to them. There are a lot of resources that are available to people that say things like the patient or the cancer. It's very kind of, in a way, cold. It doesn't necessarily make people feel like they're being spoken to as opposed to being spoken at. We really want to work with people and make them feel that there's people here that understand what's happening and we want to help them. So when you see something like "we won't stop working for you," it's really our way of saying that we're on your side and we're trying to kind of connect all these dots for people when there's a lot of confusion. In this particular slide, we talked about media relations. It's really, really important to understand how public relations, media relations, and marketing work for organizations like ours in the nonprofit world, because lots of programs that we do are very proactive. We create Destination Healthy Skin and we drive it around the country. We create a commercial or a PSA, the Big C, and we run it on television stations around the country. Oftentimes what we do is proactive in media, where we'll do press releases or statements and talk about Skin Cancer Awareness Month, or remind people to wear sunscreen before Memorial Day weekend, those types of things. However, it's also really important to understand the reactive side of things, because there's lots of news that goes on in the world of skin cancer, whether it has to do with the FDA's requirements on sunscreens or tanning beds, or the different ingredients that are available in sunscreens, different immunotherapies that are released and approved by the FDA. The media has to go somewhere. And oftentimes they'll come to us, whether it's the Wall Street Journal, the New York Times, or Channel 7 News. They're going to reach out and say, "Hey, can you get us an expert? Can you give us a statistic? Can you give us some insight as to what's going on?" And we look at it like it's our role to make sure that we know everything that's going on and have our hands kind of right there in the dough, mixing it all together so we can help get that information out to patients. It's oftentimes a forgotten skill in making sure that it's one thing to have all the information here and have access to people. It's another thing to actually get it out to the people that need it. Advocacy, I mentioned before, the FDA, excuse me. Oftentimes, we'll be talking about everything from regulation for sunscreen ingredients, which there hasn't been new ingredients approved in quite a long time, and we're always fighting for that. There's some ingredients that are available around the world that we'd love to see here in the United States. That's something that we work on. And I mentioned tanning beds. Tanning beds is another big one where some states have them banned up to a certain age, 18, 15, 16. We'd love to see them banned altogether, but they're not. Every state gets to make their own decisions. So we work on that, trying to make tanning beds either impossible to get to or more difficult. Countries like Australia have banned tanning beds altogether. They're illegal in the entire country. So we work with Congress and Senate and different lobbyists to try to make sure that skin cancer isn't forgotten when it comes to these types of things. And that's really it. I'm sometimes better answering questions because there's so many different topics. I promised I could talk for 2 hours if you wanted me to, but I promised I wouldn't. Social media is really big. As you can see here, we list out some of our social media handles. Facebook, we have about 60,000 people, maybe another 25 on Instagram and Twitter. Everything, we kind of cover the gamut. We have great videos on YouTube and it's growing. And it's kind of an interesting thing for about 19 people that are here in New York City at the Skin Cancer Foundation, how we're able to cover so many different things at the same time, mainly through the help of the doctors that we work with. So I appreciate them for everything that they do. But I think it's definitely something that you should follow, and you can see all the things that are going on in the world of skin cancer. So I thank you for your time. I appreciate everything, and happy to answer questions along with everybody else.
Thank you, Dan. That was great. And you guys really do such incredible work. You really do. It's amazing. And I second that. I follow you guys on all your social media channels. So I encourage everyone to check out their website, check them out on social media. They have so much information on there. So thank you for being with us tonight, Dan. I know you had a crazy month going on with skin cancer awareness, so we're very lucky that you're here with us.
That's what we're here for.
All right, we will now take some questions. So if anyone has a question, please type it into the Q&A box. I have one here. What are some new advances to tell if a suspicious mole or mark is cancerous without having to cut it to do a biopsy, and how reliable are they? Dr. Hale.
I can take this question.
Okay.
So fortunately, we have gotten better at diagnosing skin cancers. Of course, the most important thing is still our clinical examination, using our eyes to look at lesions. But beyond that, most dermatologists now carry a dermatoscope, which is a pocket magnifier with illumination and polarized light. So we can actually look at moles or nevi to see features that may make them more likely to be atypical or melanoma. There are some other imaging like confocal microscopy, which is a very advanced device that is not yet really utilized in individual practices, but there are a few throughout the city to really look under the surface of the skin without doing a biopsy. There are some areas that can do mole mapping, so we can send people to a hospital like at NYU, for example, where they can have a computer-assisted monitoring of moles, where they actually take pictures of the moles and then digitally compare those to previous moles, and they can actually detect changes that may have occurred based on certain algorithms with the computer. And most recently, there's something called DermTech, which we're very excited about, which is a non-invasive way to sample a mole. It's basically a tape test. That's the layman's term for it. But we use the equivalent of like a piece of Scotch tape, but it's much more high tech than that. And we basically kind of scuff up the mole, the lesion, which releases some of the RNA from the surface of a mole. And then we can lift that up, send it to a lab where it will be processed to look for 3 specific mutations that occur in melanoma. And the test is highly sensitive. So if we have a lesion of concern, but the patient is sure it hasn't changed, maybe they don't want a biopsy, or maybe it's something not that concerning, but the patient thinks it's changed. But in certain scenarios where we don't want a biopsy, we can actually non-invasively sample the mole to have a very good feeling of whether or not it may be melanoma. And if any of those genes are expressed, the patient comes back for a biopsy.
Thank you, Dr. Hale. All right, we had a couple other questions here that were for Dr. Witter. Dr. Witter, thank you for answering them. And it looks like that is all the questions. So with that being said, thank you to our amazing speakers for participating tonight. Thank you to everyone who tuned in, and remember to wear your sunscreen. Memorial Day weekend is coming up, so listen to all the great advice that you got here tonight. So thank you, everyone. Take care.
Thank you.
Thanks.
Thanks, Rachel.
Good night.
Thanks,
Bye.
Good night.
Bye.